You're listening to the Mommy Labor Nurse Podcast, episode number 45. Hey guys, so we are doing I don't even know what to call it. I guess it's an expert interview episode this week with my friend Marley, and Marley is at Midwife Marley on Instagram. I'll talk about it in the episode, but I love her little, I love her little drawings on Instagram, and I just love her. So we're Instagram buddies. But she came on today because we actually did a live together a while ago. I think I was pregnant at the time. Yeah, I was pregnant. Newly pregnant. I think it was kind of newly when COVID was going on. A while back, we did a live together and we chatted about the differences between UK maternity care and US maternity care. And it was such a cool live to do that we decided we wanted to do a whole podcast episode on it. So that is what's coming out today. So Marley is a registered midwife from Surrey, UK, and she's also mother to 5 children, including a set of twins. She's practiced midwifery in a various amount of settings over the past 11 years, working in hospitals, birth centers, and in women's homes. She cares for women from conception up until 2 weeks postpartum. Like I said, she's also Midwife Marley on Instagram, and she does these cool little cartoon drawings that I just love. And she, like I, loves to educate moms on their in childbirth, and she's passionate about helping women to have a positive birth experience no matter what type of birth they may have. So today we talked about her training, how kind of what the difference is between a midwife, because midwives in the United States and midwives in the UK are a little bit different. So we go over kind of her training and what sort of care she provides women. We talk about home birth in the UK and the differences between home birth here in the United States and home birth in the UK. And then we talk about postpartum care and their postpartum care system, which is kind of very, very interesting to me because, it's very, very, very different than here. It was a super cool episode and a very enlightening episode because, it's always cool when I hear from other people from different countries and hear how things are in different countries. So without further ado, let's hear from Midwife Marley.
You're listening to the Mommy Labor Nurse Podcast, where we firmly believe in the power of education when it comes to giving birth. Tune in each week as we dive into pregnancy-related topics, expert interviews, and a variety of birth stories. As a reminder, anything you hear on this podcast is not medical advice. Please see mommylabornurse.com/disclaimer for more details. And now, here's your host, educator, registered nurse, and fellow mom, Liesl Teen.
Hi, Marley. Welcome to the Mommy Labor Nurse Podcast. Thank you so much for being here today.
Thank you for having me. It's lovely to be here.
Yeah, awesome. And you are way far away from me. We are not in different countries. So can you start by telling listeners a little bit about yourself and your family, where you're from, all that good stuff?
Yeah, absolutely. So yes, I'm Marley and I'm a midwife from the UK. I live just outside of London with my partner and my 5 children.
Awesome.
I've been a midwife now for about 11 years. Yeah, so just over 11 years. And I've worked in all areas of midwifery maternity. So I've looked after women in the antenatal period, so before they've had their babies, throughout their pregnancies, during their labour and birth, and in the postnatal or postpartum period as well.
Love it.
So, yeah.
Love it. So you've done just a lot of different stuff.
Indeed. Yeah.
So, okay, quick question. And I guess we didn't talk about this before in our live, but so you said you've been a midwife for 11 years and your oldest is older than that, right? So you probably went through training like while you had children. Yes,
I did. Yeah. So he's 20. He's just turned 20 now.
Gotcha.
And so before I became a midwife, I was going to be a journalist, funnily enough.
Interesting.
Yeah. And I went to university and I did a bachelor's degree in digital broadcast media.
Okay.
And then I graduated when my son was, how old was he? He was about 2.
Mm-hmm.
And No, about 3 actually. And then I said, actually, I don't want to be a journalist anymore. I want to be a midwife. So I
Isn't that how it works?
That's just how it works, you know?
So fun fact, I've never said this like on, I mean, my friends know this and my family and stuff, but I've never like really like talked about it, and it's not that interesting. But I was totally, when I first went to school before I did nursing, I wanted to be like a physics major.
Oh,
like,
wow.
isn't
There
that
you
crazy?
go.
Like, I was so into science and like physics, and I had a really crazy awesome physics teacher in high school, and he just made such an impact on me that I was like, this is the coolest, science-y kind of like I just really want to do physics, and I want to teach people physics, or I want to like do something with, like I was just, I don't know. It was just a really great teacher that I had. So I went to college and I started, like pursuing that. And then I realized, yeah,
actually, no.
I think it was just my teacher that was really cool that I really liked. Then I started exploring. Then I started exploring other things, and then I got into nursing.
We all change our paths, don't we? Lots of people change their paths as you go through life.
We do.
Yeah.
Well, okay. So that was a super sidestep. So guys, today we are doing a podcast episode with Marley, and I did a live with her a couple weeks ago on my Instagram, and we just kind of, we're both, on Instagram educating people about labor and birth and pregnancy. And we kind of do it in a little bit different ways. Marley has pretty cool little, drawings that she shares that are super fun that I love. And yeah, we just kind of did a live to talk about the differences between the UK care and US care. So I was like, hey, Marley, do you want to just come on the podcast and we could just kind of elaborate for an hour? So yeah, that's what we're going to do. So I have a few questions written down. And the first one is, I guess we kind of touched on it a little bit, but what sort of training did you go through initially to become a midwife in the UK, and kind of what does that look like? Is it all the same? Because I actually did, you probably saw maybe my post I did last week where I talked about how it's very different in the United States. Midwifery care is not the same sort of training all over. So I want to know how it is in the UK and what you went through.
Yeah. So in the UK, obviously we're a much smaller country. So the standards throughout the UK are exactly the same. It doesn't kind of vary from state to state or anything, or from county to county. It's the same throughout the country. So there's currently two ways of becoming a midwife at the moment. So the first way is if you're already a registered nurse. So say you've gone to university, you've got a bachelor's degree in nursing, or you've got a diploma in nursing. So years ago we used to do diplomas, but I think they're phasing those out now. So now you can only become a nurse if you do a bachelor's degree. But if you're already a registered nurse with the Nursing and Midwifery Council, then you can do like an extended 18-month program to become a midwife.
Okay.
If you're not a nurse, so if you've got no background in general nursing or anything, then you can still become a midwife without doing your nursing first. So it's what we call a direct entry midwife.
Okay.
Midwifery program. So in that instance, what you'd have to do is you'd have to go to university and apply to do a Bachelor of Science, I think it would be, in midwifery or pre-registration midwifery. So that's like a 3 or 4 year course, depending on the university. It's usually around 3 years. And those are literally the two ways you can get into midwifery. So either doing your extended course for 18 months if you're a qualified nurse, or direct entry, you have to do a degree. And that is via university. And then what you'd do is you'd spend half the time at the university. I think you guys call it college over there, but it's the same. It's the kind of thing.
Well, we call it university, but we call it college. But we have the University of North Carolina. But yeah, typically like if somebody's we don't call it university in the same regard, I guess. Yeah, you're right.
Okay. Yeah, it becomes confusing because when we leave school, so we leave school at 16, you see, and then we go to college. So we go to college between 16 and 18.
Gotcha.
And then from 18 onwards, then we go to university. So that's where sometimes it becomes a little confusing. Yeah, exactly. So that's basically how it works. when I did my midwifery, we still had what we called diplomas. So we had, you could either do a bachelor's degree or you could do a diploma, which is, you still learn the same things, but it's a slightly lower level, I guess.
Yeah.
And to do that, you would be funded. So the government used to give you a bursary, which is like, I don't know, a few £1,000 a year to become a midwife. But with a bachelor's degree, I don't think you get the bursary, but what you do get is you can apply for like a loan instead. So things are different now as to what they used to be, but there's still, it's only 2 ways of becoming a midwife at the moment.
Makes sense. And that kind of reminds me of how just general nursing is here in the United States, because there's a couple of different ways to get a nursing degree, like not talking about midwifery or anything.
Right.
Because you can still they do still have some diploma programs here in the United States, but kind of the bigger difference and the route that I took was I went to a community college, which is basically it's just a different degree. It's like like you said, like a lower level degree, and I could specialize in nursing, but then I could still take the same licensing test that someone could take after going to a 4-year, like a bachelor's degree. But the advantage to going to a community college is you get it done a little bit sooner. Yeah, you have a lower, it's like a kind of a lower degree, but it's the same license and it's a lot cheaper. So like if you go to a community college, it's, the funding is a whole lot cheaper. And what I honestly did was I went that route. And then when I started working for the hospital that I work at, they give tuition reimbursement. So I just went back to school and did online school until I was able to get my bachelor's, and now I just have my bachelor's degree. So it's kind of similar-ish.
Yeah.
Yeah, so cool. Well, awesome. Well, let's go into the next question. Next one is just like, what sort of care do you provide to women? I know you kind of talked about it a little bit in the beginning, but let's just go over an overview of all the different kind of things that you do at work.
So as midwives, like I mentioned at the beginning, we basically look after women from booking, which is like a few weeks after conception, when they find out they're pregnant, right through till about a couple of weeks after the birth.
Okay.
So that will include things like running antenatal clinics. So when they come, when they have to see somebody for their kind of checkups, they would come to visit the midwife. Usually around, so the first one's at booking, so that's at about 9-10 weeks. That's their first appointment, and we do like a lot of load of blood tests and things like that, and checks. And then the next appointment is usually about 16 weeks, and then we see them again at 25 weeks, etc., etc. And then obviously we see them a lot closer, a lot more often towards the end of the pregnancy.
Yeah.
And then midwives who work in the hospital on the labour ward or in the birth suite, then the birth centre, then they are the ones that will look after a woman throughout her pregnancy, throughout her labour labour and her birth, and then will discharge her home once she's ready to go home from the ward. And then we've got midwives who work out in the community who will then go and visit the mums at home, and that will also run postnatal clinics. So we usually do like the first visit when they've come home from the hospital, and then subsequently we get the women to come to a postnatal clinic where we can kind of check them over, make sure their stitches are okay, make sure if they've had a cesarean section that their wound is okay, and just to do general checks on them and the baby as well, check on breastfeeding, check on baby's weight, those kinds of things. So it's kind of like an all-round, but what most midwives do is when we qualify, we kind of rotate around different areas. So we might spend a year working on the delivery suite, then we do a year working on the postnatal ward, and then we do a year working maybe in community, and then we finally settle down into the area that we like. So what I did is I did that. I rotated around and worked in lots of different areas. But then in the most recent years, I've been working out in the community. So I've been visiting women at home, running antenatal clinics and running postnatal clinics as well. So therefore I kind of see women throughout the whole process rather than just being sort of on the ward and just seeing them for that time when they come in for labour and delivery. I kind of see them before and after. So yeah, it's quite good because we kind of get an all-round view of women and what they, and their journeys, as it were.
Yeah. No, I love that. That's cool. And it kind of reminds me of like in the United States, doctor would go through medical school and then they would do like a residency, what's called a residency. And they kind of do that where they hop around, they go to, they usually have an idea of what kind of residency program they want to do, but they still try to rotate them in different, like if somebody wanted to be an OBGYN obstetrician, they would go through, emergency department rotation and family doctor rotation and just kind of get all avenues until they kind of more specialize into OB.
Yeah.
So it kind of reminds me of that. So that's cool. Well, awesome. Well, let's go to the next question. So this one is about home birth. And I know that home birth is very different in the UK than it is in the United States. And just, I think a lot of people are just curious about home birth and how the standard of care is over there, because I think, I personally think you guys do it fabulously. And I think it helps that obviously you mentioned, you guys are a much smaller country, so it's easier to have standards of care. But I guess I wanted to just know if you could touch on home birth in the UK, or what kind of are the standards of care? And just kind of elaborate. Somebody who doesn't know anything about home birth here in the United States, tell us all about kind of how it works in the UK.
Sure. So I think the first thing to point out is that over here, obstetricians and midwives work very close together. There's not a kind of them and us or anything like that. We work very close together, and because of that, when guidelines are drawn up, so guidelines for home birth, they are done, with midwives and obstetricians in conjunction with each other. So home births usually, it's kind of two models really. So the main model would be a home birth that's facilitated by the hospital midwives. So all midwives in the UK, or the majority of midwives in the UK, will work at a hospital. And a hospital that is also occupied by consultant obstetricians and other various types of obstetricians as well. Yeah. Different grades. So as part of the hospital, we have what we call a community midwives department. So these are the midwives that, and I'm one of them, that will then go out and visit the mums. They'll run clinics during the week. They'll go and visit mums at home, etc. But they also do home births. So the community midwives team, they may have like a sub-team of home birth midwives who specifically go and do home births, and that's it. Or it might just be the community midwives would do the home births. But they also, they can also get called in to work in the hospital or work in any other department as well, because they're employed by the hospital. So the guidelines are drawn up with the medical team as well, or the obstetric team rather. And they would form part of what we call NICE guidelines. I don't know if you've heard of NICE guidelines. It basically stands for the National Institute of Clinical Excellence. So in terms of obstetric care, midwifery care, maternity care, that kind of thing, all hospitals will have to kind of follow the guidelines that NICE set out for us. Okay. And that will include home birth as well. Gotcha. So what would happen is if a mum came to us at say 10 weeks and said, hey, I want to give birth at home, then we say, okay, we have a chat about it. And what we would do is, as we're booking her in, we see what risk factors there are, so you're well aware that some women to have home birth might be more risky than other women, so we kind of go through their history and we say, well, according to X, Y, and Z, then you are a slightly high risk for, or you don't, not a high risk, but you don't fit in with the criteria for a home birth. But that's not to say that you can't have one, because it's not down to us to say to a woman, you can't give birth in your own home. Okay. Gotcha. That's down to her to have her basically come to an informed decision herself. And it's down to us to kind of say, right, these are the risks, these are the pros, these are cons, etc., etc. We don't advise it, but if you want to do it, that's something we will support you with, blah, blah, blah. On the other hand, if somebody is totally low risk, no previous cesarean section, or no risk factors at all, and she wants to give birth at home, and there's a home birth team in her area or attached to the midwife's office, then absolutely fine, she can go for that. And what we'd do as midwives is we would just follow exactly the same guidelines that you would do with anybody else in early labour or established labour. But the only things that are different really is that obviously at home you can't have an epidural.
Right,
you know?
right.
The midwives would carry around the nitrous oxide, the gas, or we call it gas and L, Entonox would carry that.
Mm-hmm.
Some maternity units may have certain opiate drugs as well. But I think that's kind of diminishing, more and more.
Yeah, you're getting kind of away from it.
Yeah. But we would also kind of carry around equipment and things.
Yeah.
Carry around equipment and things that we need in case of an emergency. So resuscitating an infant or resuscitating a mum. So the guidelines are pretty much set in stone, as it were. But every woman that comes through, we kind of try to cater to her specific needs and wants, really. But the other model that we have, that's that with the hospital midwives. But the other model we'd have is with private midwives. So private midwives would work independently, and they can do home births as well. But again, they still have to adhere to the NICE guidelines. They still have to follow the conduct that's set out in the Nursing and Midwifery Council, like any other midwife does. Mm-hmm. And they have to have adequate insurance. So midwives who work in the hospital, they're covered by the hospital insurance. Private midwives have to be covered by their own insurance.
Like a malpractice insurance.
Well, basically just like an insurance that covers them if in the event of any any litigation. Yeah, absolutely.
Yeah. Makes sense. I did have one question while you were talking. So if someone their first visit, they come in and they aren't really sure, if they want to do home birth or hospital birth, what do you kind of counsel them on? Do you you probably don't encourage them. I mean, would you encourage them if they check all the boxes and they are super low risk? Do you guys encourage them to do home birth because that's, generally like a safer option because they're low risk? Or do you still kind of say, hey, this is this and this is that? Well, let us know by 39 weeks or whenever what you want to do.
I think it depends, because I don't think we're supposed to encourage anybody to do anything. And I think, every midwife is different. And I think it depends on what's available in the area. I mean, like where I live, we have the option of a home birth, or there's a birth centre that's down the road from my house, which is where, as a midwife, we would naturally refer every low risk woman just goes to the birth centre. That's where we refer them to. So we save the obstetric unit is next door to the birth centre. It's literally the building next door. Mm-hmm. So, but we save that for the women who are high risk, and we refer everybody who's low risk will just automatically get referred to the birth centre. But we would say to them, right, options on where to give birth. You can either give birth in the birth centre or you can give birth at home. And then we just leave it as that. And then that kind of plants the seed in their head. And then if they want to give birth at home, then they come back and they talk to us about it at a later date, because sometimes at 10 weeks, 11 weeks, nobody really knows what they want to do.
Oh, yeah. No, you're like, I have no clue, especially if this was maybe an unexpected pregnancy or, it's your first pregnancy. Yeah, you just, I get that. Yeah. And it's it's 30 weeks away. I'm not going to think about this.
That's the last thing we're thinking about.
Yeah, that makes sense. So one last question before we get to the next one. With birth centers, can you get anesthesia there? So would you be able to get an epidural there?
No.
Okay. So that's just at the hospitals.
Yeah. So if you've got a lot of the birth centers are actually attached to hospitals. So if somebody's in the birth center and she's a first time mum and she wants an epidural, she just gets put in a wheelchair, wheeled along to the delivery suite. Off you go. And you can have one in there. Yeah.
Gotcha. Okay, cool. All right. So the next one is, we're starting to talk about it, pain medications. So what are, I guess we've already kind of answered it, but what are some of the most popular pain medications, analgesia, options that most moms go for, that you maybe not encourage, but you give them options like, this is what we have at home. This is what's available in the birth center. This is what you might have in a hospital.
Yeah. So there's really three main types of pain relief that we use here, and that's the gas and air. And everybody, well, almost everybody goes for the gas and air. And some women are happy just to use that throughout the whole labour and just give birth. Some women, it's kind of like a tier system, you know. So it's like we kind of step up. If somebody says, I need something else, say, okay. And we talk to them about opiates. So we talk to them about a drug which we call pethidine. And we obviously let them know the pros and the cons for that as well. And then if they decide to have it, we give them some of that. If they decide they don't want that, then we talk to them about an epidural, which is obviously the most invasive of all three types of pain relief. But if they want an epidural, then they can have an epidural. But it's something that they can't have at home, obviously, and they can't have in the birth centre because it needs to be given by an anaesthetist. But usually I would probably say, in my experience of being on the delivery suite, I would say at least 90% of women will all start off with the gas and air. You know? But even prior to that, I might say to somebody, you know what, if you're at home and you're in early labour, get in the bath, use some warm water. You know, that might help as well. And some women decide that they want to have a water birth, and on the delivery suite, which is the obstetric led unit, they actually have a birthing pool there.
Oh, cool.
So so some women might want to get in there to begin with before they go on to something else. Very rarely, occasionally, you have a woman who just comes in and says, no, I don't want anything else, I just want an epidural.
Gotcha.
That's my first choice and my only choice. Occasionally you get that, but not very often. Usually women will start off with the kind of the less invasive medications first, and then kind of work their way up if need be.
Yeah, no, that's very interesting, because it's obviously we talked about this in our live too, that it's very different in the United States. We kind of don't necessarily encourage people to get to get epidurals, at least at the hospital that I work at. But it's kind of just more of, hey, like this is a hospital, you know, you do these are your options. What do you want to do? You know, it's more of like that kind of question. And hey, these are the pros and cons of getting an epidural. Hey, these are the pros and cons of getting IV pain medication. And our hospital we do have nitrous oxide available, but a lot of hospitals don't even have the nitrous oxide available. So I think it's just a different dialogue in the United States. But I did want to ask you, so I feel like the nitrous, and this could be me, I might be wrong, but I feel like our nitrous oxide is a different concentration than y'all's. Maybe. So tell me what exactly gas and air is.
So it's a mixture of nitrous oxide and oxygen.
Okay.
It's a complete mixture. And to be honest, off the top of my head, I can't even remember what it is. If it's 80-20 or 50-50, I can't remember. So I don't want anyone to kind of hold me to this. But it's laughing gas, basically.
Yeah. And I think ours is just like less nitrous oxide. I think that's all it is, because it's the same.
Have you ever tried it?
I did. I tried it during my labor and I did not like it. But you know what? I think there's also a difference, because I think over there, your mask system is different. So over here, because I've seen videos of people giving birth in the UK, and the thing that they put in their mouth is like just a little...
It's a mouthpiece. Yeah,
it's just a little mouthpiece. It's not like a big face mask.
No,
and over here, that's all at least that's what it is in my hospital. I don't know how it is in other hospitals. It's like just a big, almost like a non-rebreather, big oxygen mask that is like very just it's too much on your face. That's personally why I didn't like it, was because it was just like impeding my breathing. Like I was doing so well just breathing by myself, and then I tried this nitrous oxide on my face, and I felt like I couldn't breathe with this like big mask on my face.
Oh gosh, no. The thing is with the mouthpiece. I mean, I've used gas and air for 3 of my births.
Yeah.
And when you breathe into it, you can bite onto it as well, and I think it just helps kind of focus when you're having those contractions, and then you take it away. You take it away when the contraction's gone. You take it out of your mouth. Whereas if you've got it's constantly there. You know, whereas with the gas, with the mouthpiece, you can just take it out and put it to one side for a few minutes until the next contraction comes, and then you start breathing on it again. But I found that it helped to, it doesn't take the pain away completely. It just makes you kind of feel a bit, drunk.
Bit loopy.
But it kind of helped me and other women that I've worked with as well to focus on breathing, because you have to kind of breathe deep on it, don't you, to kind of get the full effect. But it's, I mean, everybody's different. Some people are going to have adverse reactions to it and think, oh no, I don't want this, I'm feeling out of control. And other people are like, yeah, that's just great stuff. It's everybody's different. And if you puff on it too much, though, it can make you feel nauseous. So that's why you have to just be careful that only use it when you've got a contraction. Some women just like to puff on it the whole time, and it's like, no, you've got to kind of put it down for a bit. Otherwise it can make you feel a bit sick, which you don't want that.
Yeah, no, absolutely. All right. Well, this next question is just, we're kind of off topic, I guess, now going away from pain medications, but I did just want to know kind of if there's any opportunity to advance your career in midwifery in the UK, because they're definitely over here. So, it's a little bit different if you're a physician, there's different advancement opportunities, but nursing, there's definitely a lot of advancement opportunities. You can get a master's degree and you can go here and there. So I wanted to know if once you become a midwife, that's kind of the top level that you are in your career, or if there's any sort of like other job that people get, other career that people get that's like a little bit higher than midwife, or if anybody goes, if there's an easy way to go through obstetrics and go to medical school and become, a physician.
Yeah. So once you qualify as a midwife and you've got your bachelor's degree and you start working in the hospital, you have to get a certain level of experience before you can really go on to do anything else. And that's usually about 2 years. But we have what we call specialist midwives. So we have like the diabetes specialist midwife.
Okay.
And we have a vulnerable women's specialist midwife. So these are the midwives that work with women who have problems with substance abuse, women who have problems with domestic abuse, that kind of thing. Women that are more vulnerable, So we have one midwife assigned to all of those women. Someone else who may specialise in antenatal screening for anomalies and that kind of thing. And these midwives who specialise, then they're usually paid at a higher band, a higher grade than your standard registered midwives. And there's also the opportunity to go on to become a matron or to become a consultant midwife as well. But that's still kind of working in midwifery. You just kind of more specialised and more focused, really.
Gotcha.
But if you want to kind of move away from midwifery, there are other things you could do. You could become a health visitor, which is basically like a public health nurse. But they're very kind of specialised in what they do within the local community. They work a lot with families who've got children under the age of 5 years old, and they kind of guide that family through the kind of the early years and help them with things like weaning and development of the baby, immunisations if that's what the parents want to do, school development, behaviour. So there's a few ways, a few things you can do. As in regards to medical school, if you became a midwife, I don't think it would fast track you into medical school. You'd still have to do I think it's about 7 years. So it might stand out more on your CV or your resume, but I don't think it would kind of give you any shortcuts. You'd still have to do the same amount of training that any other medical student would have to do if they wanted to go. Would go on to become a doctor. So
makes sense. That's kind of how it is over here too. I mean, nurses typically don't. I guess the only difference would be there are definitely some nurses that I work with who I know, and they go to nurse practitioner school, and that's not necessarily a physician. You're not going to medical school, but it's like you can have some similar roles as a physician, like you can prescribe medications, you can, you can work in clinics and see patients pretty much as a physician, and do a lot of roles that a physician does, but you're still overseen by a physician. So it's kind of the same thing. Like if somebody was a nurse for a long time, advance their career in nursing, they still would kind of have to like start at the bottom to go to medical school if they wanted to become a physician. So makes sense.
Absolutely.
All right. Well, this next question, we have a few more. We talked about this in our live a little bit, and I really wanted to have you talk about it again and touch on it, because this question is about postpartum care and how your postpartum care is set up. So I want people to know how different, because obviously a lot of these people listening to the Mommy Labor Nurse podcast are in the United States. So I want to hear how your system, your postpartum care system, is set up in the UK.
Okay, sure. So the moment a lady leaves the hospital, her notes will go over to the community midwife's office. And if she's not from around the area, say she's given birth somewhere and her home is 100 miles away. Okay. Let's say she was on holiday somewhere and she happened to give birth at a hospital. Then what the hospital would do is that they would email or fax over her details to the closest hospital that has a maternity unit next to her, where she lives, and would inform the community midwives that she's now gone home, she's been discharged. So so the day after she comes home from hospital, the midwife will be knocking at her door, and she will be visiting her and the baby and just checking them over to make sure they're all okay. And I think a lot of it is just to kind of be that friendly face, and the mum knows that there's somebody there that she can kind of talk to if she's got any problems with anything, because we get all the normal questions like, oh my gosh, am I feeding the baby okay? Is the baby okay? How do I bath the baby? Because we don't bath babies in the hospital usually. The mums do that at home. And sometimes, I mean, years ago we used to send maternity assistants around, and even midwives used to go around to the mum's home and help her bath the baby for the first time, because a lot of new parents are quite nervous about that. But we can't do that so much now, but we try to give them as much direction as possible. So we'll see them on the first day. Any problems they might have, then we kind of go over that. If somebody's had preeclampsia, for example, she might need to have her blood pressure measured every day for 7 days or something. So we would do that. Yeah, so we would do that as well. And then if everything's okay, we see them again on day 5, but that's usually at one of the clinics, and we get them to come to the clinic unless she's had a C-section. If she's had a C-section and she's finding it difficult to move, or if she's had, a perineal tear or something, and again she's finding it difficult to move, then we will go and visit her again at home. But where possible, we get them to come to the clinics. And then it'll be the same on day 10. So we weigh the baby, check the baby over on day 5 and day 10. And then we would discharge her, as long as everything is okay, on day 10 into the care of the health visitor, who will basically be assigned to that family for the next 5 years until the baby goes to school.
Gotcha.
Yeah, but I mean, if there's any problems in between days 1, 5 and 10, then we just, we make extra appointments if we need to. You might have a mum who's having real problems with breastfeeding, so in which case we might get someone to come around and see her and give her some support. So it just depends. Everybody's different, but yeah, it's usually at least 3 visits that we do,
like initially in those first 10 days. No, that's great. That's awesome. Very, very different than it is in the United States.
Yeah, so I've heard.
Yeah, I think we're starting to understand. Like ACOG came out and made a statement, I think it was it last year, 2018, that they basically said, we know we're not doing this right. We know we need to see women, before, because basically you get discharged from the hospital and then you don't see a provider unless you have preeclampsia or you have, something else high risk, little bit going on. You would be seen at like 2 weeks, maybe postpartum, but typically it's a 6-week visit. You leave the hospital and then you don't see a provider again for 6 weeks. And there's not, they give you numbers that you can call, like, hey, call us if you feel like you are having postpartum depression or you're having these symptoms or whatnot. So it's not like they just kind of leave you hanging, but it's not that specialized, like, okay, we're definitely going to see you at day 2 and day 5, day 5 and day 10. And then, so it's, just lacking. And we understand that as a country and, like here, but it's difficult because it is such a large country and we have all these different states and everybody kind of does
things differently.
So it's hard to get a really concrete standard of care, but we know we're not doing it right. And we know we need to do better. Because
I just worry about the mums, especially the ones that might not know how a perineum should be healing properly,
I know,
and they may not get in contact with you, unless they're kind of in excruciating pain or something. And I think it's hard because some women might not know that having a fever of 38 is abnormal.
Right, right, exactly.
So it's down to us to kind of make sure that they do know that, and that that they're referred into the hospital if there's any concerns. So
right.
And those first few days are very, very difficult, aren't they? Because you know what it's like. You're a mum, and it's so tiring, and it's like a big blur,
Yeah. Oh, for sure.
And all we're thinking about is looking after the baby. We kind of forget about ourselves sometimes.
For sure.
So it's good to have somebody else to be able to look after you and have your best interests at heart.
For sure. Absolutely. So important. All right. Well, this next one is, we have 2 more questions, guys. So this next one is just something that I heard about UK care, maternal health care. So I wanted to touch on it and see kind of what you thought about it and if it's true or if it's not. So one negative aspect that I have heard regarding UK care, maybe not just in the UK, but just like smaller European countries, is that there are super long wait times, lack of supplies, or like poor services, similar to how it kind of is sometimes in the United States, depending on the area that you're in. So I just wanted to know if you could touch on that, if that's something that is kind of true that people do tend to complain about, that the healthcare system is lacking in, and if there's any other kind of really big issues that maybe is not apparent to me living in the United States that people would deal with in the UK.
Yeah, sure. Well, there are, you obviously know how our system's set up over here. So we have a national health service. So the healthcare is free to everybody, which is great on one hand, but then on the other hand, it can become difficult if that system isn't given enough funding, because then it kind of affects things like staffing levels,
Right.
If you've got a midwifery training course, but the government aren't funding enough midwives to be trained, then we're going to end up with lack of midwives later on, etc. So a couple of things I think that women do complain about sometimes, or a lot actually, is clinic waiting times. Yes, absolutely. So if you have got an appointment in the antenatal clinic at the hospital, for example, and you're going in and you're going to see the doctor, say you're high risk, you're going to see the doctor, and you've got an ultrasound scan as well, you could be there for 2 to 3 hours sometimes.
Interesting.
Yeah. So, you could be sitting in the waiting room with 30 other women who are all kind of doing different things as well, going to see different people, doctors, midwives, sonographers. So there have been some issues with that. And it's just due to the sheer number of women and not enough staff, I guess.
Yeah.
Most women are happy with the labour and birth care because, again, most of the time it's 1-to-1. You have one midwife, one woman, as much as possible. But then when we go to the postpartum or postnatal ward care, unfortunately, because we have a ward with, let's say there's 12 rooms, 12, 14 rooms in a ward. So you've got potentially 12 mums and 12 babies, so that's 24 people. You might only have 2 midwives on that shift, looking after everybody. They'll have a couple of maternity assistants, maybe they might have a nursery nurse, but it can be quite difficult when you've got lots of women who are needing support with breastfeeding usually, and they're ringing the call bell and you can't get there quick enough because you're dealing with somebody else. So a lot of the time it depends on what day you give birth. It's like some days you can go in there and there's hardly any women in there, and it's great because you've kind of got all the midwives to yourself. Other times you can go in there and it's so busy, and actually it's probably better off if you're at home, because at least you've got your family who can look after you,
Right.
So that's why we get a lot of women who, if they're low risk and they're straightforward, they ask for a 6-hour discharge. They will literally give birth, especially ones who've got children at home, give birth. They've got no tears, they've got no problems. They're getting up and they're walking about. They haven't had an epidural, so they're up and they're walking about. And they get discharged home if they want to. We don't force this on anybody. Usually most women will stay in overnight. But if they want to, then they can go home after 6 hours, and then we just visit them the next morning at home, because they feel like they've got more support at home. So yeah, I think that with the postnatal ward care, sometimes that can be a bit of an issue. Yeah,
I mean, it
just
makes
in
sense.
terms of staffing,
Yeah, no, that makes total sense. And I mean, I would be concerned as the midwife, taking care of these women for my own license, or just like being able to take care of all of these women at once.
Yeah.
What if one has an emergency and another person has an
Oh
emergency?
gosh.
And it's just scary.
You
So
know
that's
what?
why.
We've been in that situation before as
Yeah.
well. When we've there's been 2 midwives on the ward, and one of the ladies, she's postpartum, so she's only given birth maybe, I don't know, 8 hours before, and she's just come from the ward, and she's had a hemorrhage, and we've had to kind of rush her off the ward, but then we can't leave the ward because there's other women on there.
Right.
So we're like, hang on a minute,
it difficult.
We need somebody to come and help us. So that can happen sometimes, which is not nice,
No, it's scary, for the healthcare professional. And it's kind of I guess a little bit different over here, because we do have, it's not like country staffing ratios, it's based on the hospital, but they do kind of just have standards of like, hey, this nurse on this certain, like in the ICU, or even at my hospital in labor and delivery, if somebody's in active labor, it can, you can only be 1-to-1. You can't have more than one patient. In the ICU, you can only be 1-to-1. In, the emergency department, it can be 3-to-1, or in med surg, it can be up to 6-to-1 or 5-to-1. It just kind of depends on the
level of
hospital.
care.
Right. On the level of care and on the hospital and what their standards are. So I wonder if is it similar over there, or is it just about how big the hospital is and how they staff?
It's to be honest, I think it's how big the hospital is and what the staffing is like. But I think it's pretty much the same across the board with most big maternity units. In the UK, it's like, well, 2 midwives is enough. Well, it's I think the hospitals that I've worked at, it's supposed to be three midwives, maybe 1 midwife to 6 postpartum women.
Okay. Gosh, that's so many. I feel like
it is, and especially like I said, when you've got one woman who you're sitting with her for an hour trying to help her breastfeed the baby, and then you've got somebody else who needs help, and it's like you just cannot be everywhere, and you've got to do observations on all these women as well, and make sure they get their medication. So we do the medication round as well.
Yeah.
So there's a lot to kind of try and keep up with. Yeah.
And what are so over here, typically nurses, they do 12-hour shifts. Do you guys do 12 hours over there, or what are your hours typically?
Yeah. So most midwives in the hospitals will do what we call long days, which is 12 or 13-hour shifts.
Yeah. Yeah. Okay.
Occasionally you can split them, so you can do like a 7 in the morning till 2 in the afternoon, or 1 in the afternoon till 8 p.m. or a night shift, but it's usually sort of 12, 13-hour shifts that most of us will do.
Gotcha. Yeah, no, that's how it is here. Good too. All right. Well, this last one is just the last question wrapping up. I just wanted to ask you, Marley, if you had any tips for any UK listeners, if I have anybody out there who's from the UK, or maybe they're moving to the UK and they're interested in becoming a midwife, kind of where do they start?
Okay, well, the first thing would be to make sure that you have the right qualifications to be able to get onto a midwifery course in the first place. So if you are kind of out of school, if you're a little bit older, for example, and you've had kids and you want to go into it, then if you've been to college and you've got A levels, or you've got what we call a BTEC, an advanced one, or a GMVQ in health and social care, for example, then that's usually enough to be able to get into university. If you haven't got that, then what you can do is something called an access to nursing course.
Okay.
And that should be enough to then get you into university. So start off by making sure you've got the right qualifications to get onto the course. And then my recommendation would be to do some research to begin with.
Yeah.
Join up at forums, like there's one called, I think it's called studentmidwife.net or smnet, I think it's called.
Okay.
Where literally you've got a whole thousands of student midwives and aspiring student midwives as well, all talking about everything to do with the course, and from which university to go to what books to buy, what to write in your personal statement. But you need to do things like understanding what the role of the midwife is, because if you go to an interview, say you get an interview, or you get an application form and you write down, hey, I want to be a midwife because I like babies. Right. That's not going to get you onto the course, because for midwifery over here is about the woman, obviously the baby. the baby is the end result, absolutely.
Right.
But the midwifery is about the woman, and it's about her and taking her through that journey. So, and I get this all the time. I get messages on Instagram by young girls, and they say, "Oh yeah, I love babies. I want to be a midwife." And it's like, if you love babies, become a NICU nurse. You know, become a pediatric nurse, not a midwife.
Oh yeah, I can't tell you like how many. Yeah, we don't. I mean, we're still required, obviously, as you guys, to know how to resuscitate a baby and how to do standard baby care and stuff. But like, do I sit around and hold babies all day? No, I'm taking care of the mom. So no,
exactly.
I completely agree. I wanted to get that website for, you said it was studentmidwife.net.
I think it's called studentmidwife.net.
Okay, we'll put that in the resource.
Or SMNet. Yeah, something like that. But I remember I joined it many years ago, about 15 years ago, when I was training to be a midwife. So
gotcha.
and I found it a valuable resource for me. But it kind of, if you're ready to make your application, then you go to what's called the UCAS, which is the University and Colleges Admission Service, and that's how you apply to become a midwife. But you need to kind of have done all your background research first.
Gotcha.
So definitely the studentmidwife.net forum is a great place to start.
That's good. That's a really good resource. And then just one question while you were talking that I thought of. So if you, and I don't know if you know the answer to this, but if I am a nurse, labor and delivery nurse in the United States, and I move to the UK, or vice versa, if you're a midwife in the UK and you move to the United States, I wonder if there's any kind of cross training that they offer.
I think there is. I think there is, because we've had a few midwives or nurses from the US that have come over.
Okay.
I've got a feeling there might be like a little court, like an abridged refresher. Yeah. Like a few months or something that you might have to do.
Gotcha.
But I don't think you'd have to do the whole program. It depends where you're from though, and what standards they have in that particular country. Like, there are some countries in the EU, in Europe, where midwives can come straight over and start working straight away, you know. But there are some countries where it's like, sorry, you have to start from scratch. You have to, go and start training to be a student midwife, to be a midwife from scratch. So yeah, it does depend where you go. But I think if you come from America, I'm pretty sure that it's easy enough to kind of get into it and transition into and vice versa.
And I bet if you have, and you guys have it's a bachelor's degree program, and I would think that you would not probably transition into our role as a midwife here in the United States, because a midwife and a labor and delivery nurse is different here, but you would absolutely be able to work as a labor and delivery nurse here, probably without any problem at all. You would just probably have to take our US based licensure exam, but you wouldn't have to go to any additional schooling. So, but yeah, it is interesting how it's just different. So I think that's cool. Well, that's a good way to wrap up things. Thank you so much for coming on. Can you just tell people where they can, can you just tell people where they can find you? Because I know, we referenced it in the beginning of the episode. We met each other on social media. So if people want to check out your social media, tell them where they can find you.
Absolutely. So I'm on Instagram. Midwife Marley. So at Midwife Marley. And I'm also on Facebook under the Birth Coach. And I have a website as well, which is just like a blog. So I've got some articles on there about pregnancy and birth and beyond. And that's just www.midwifemarley.com. So if you're interested, just check it out.
midwifemarley.com. Love it. And I'll leave all those links in the resource in the show notes page for people to check out if they want to follow you. Well, thank you, Marley, so much for coming on. I think this was such a cool little episode that we so interesting, isn't it? Yeah, like so many differences. I mean, I want to talk to, I think I said at the end of our live that I want to talk to different people from different countries and see how it is, in Brazil or in, Germany or in, this area or in China, or in, a different
This would be your mission now. So
I know, right?
Everywhere around the world.
I need to make my way. Yeah, exactly. All right. Awesome. Well, thank you so much for coming on again.
Thank you for having me. You take care.
You too. Are you looking for birth education? did you know that I have 2 fabulous birth courses that are super affordable? Well, I do. Head over to mommylabornurse.com/podcast to take a short quiz to see which birth class is for you. When you purchase either birth course, you'll have full access to it forever. And that means it will never expire and you can access it throughout any stage of your pregnancy or for any subsequent pregnancies that you have. You'll also gain free access to my Facebook group, linked to the class where you can ask questions about your pregnancy, share your birth story after you give birth, read other people's birth stories, and get to know other members who are in the course. There is also a money-back guarantee, so if you are at all unsatisfied with your purchase, please send me an email at hello@mommylabornurse.com for a full refund. There's really no risk to signing up, and I promise you will learn a ton about what's to come when you give birth. As a listener of this podcast, you automatically get 20% off any purchase if you use the code PODCASTLISTENER. I've had tons of moms just like you enter these birth courses and have fabulous, wonderful, empowering births because they feel so much more educated about what's to happen. So if you are at all curious about birth education, again, I encourage you to go to mommylabornurse.com/podcast and use the code PODCASTLISTENER to save 20%. All right, so that is it for this episode of the Mommy Labor Nurse podcast. You probably follow me on Instagram because that's probably where you came from. But if you don't, head over to Instagram and follow me at mommy.labornurse for more. That is certainly where I am most active. I also now have a separate Instagram for just this podcast, so I encourage you to follow my second account at mommylabornurse.podcast as well if you want podcast updates. Again, that is at mommylabornurse.podcast. As always, you guys know that I also have a website where I have tons of articles all about pregnancy, birth, breastfeeding, newborn stuff, and more at www.mommylabornurse.com. I want to hear more from you on how much you love this episode of the podcast or how you think I can improve. So leave me a comment on one of my pictures, send me a DM, or send me an email with all the love. All right, guys, I will see you same time, same place next week.